Okay, good morning. Can you all hear me?
Yes, madam.
Okay, now actually, Dr. Rupila is here. He's wondering whether you all can find a rubber ball and a small ribbon for him to demonstrate the eye movements. Whoever can you find it? We'll give you a few minutes because lecture will start at 11:15. So if you can find a rubber ball and a ribbon and a drawing pin, actually, something to just sort of pin the ribbon to the ball, right? So that you can, so when he's demonstrating it, you can look at it. You can also do it at home, right? So if you can you sort of do that? Okay, we'll give you a few minutes. I will introduce you. Okay, no, good morning to all of you. Can you hear me?
Yes, we can hear you, madam.
Okay, right. So I would like to introduce you to Dr. Tavisha Udupihilla. He is the consultant eye surgeon at the Sirimao Bandanayaka Hospital. So he will be talking to you about the clinical anatomy of the eye and the orbit. Right. So we will be shifting from this screen share, these slides, and then video as well because he wants to do some demonstrations. So if there's any problem, if you can't see or hear, just let us know. Okay. So I will hand it over to him.
Okay, thank you, Himani. Okay, good morning. Sorry.
Yeah, you can go from there.
Yeah.
Make her.
Good morning, everybody. We'll be discussing some of the clinically important aspects of the ocular anatomy. Can everyone hear me?
Yes, sir.
Okay. So now obviously it's not possible to discuss everything and go from place to place and discuss the clinically important points in all of them. What I'll be doing is I have selected a few common problems and we'll be discussing the anatomy relevant to these problems. Okay, the first problem: a 9-month-old baby is brought to the eye clinic by his mother, who complains that the right eye has been tearing since birth and that the tears are overflowing right onto his cheek. Okay, so what do you think is going on here? Just think. Why is he tearing? Yeah, I need at least a few people to respond. Just give me a minute. Hello? Hello. Okay, thank you. Yes. Can everyone hear me?
Yes, sir, we can.
Yes. Okay. Then you have to answer, okay? Yeah. So why do you think he's tearing? What are the possibilities? Just think. No, you don't have to even be a medical student to say this. What could be going on?
So, is there an irritation of some sort?
Sorry? Irritation. Okay, good. So irritation means either increased secretion, right? Too much tears are being secreted. Or any other thing? Whatever tears that are being secreted cannot go out. So that is also a possibility. So usually the problems we get is that the tears are not going out. So for that, we have to learn the anatomy of the tear drainage system. So when the normal drainage path is blocked, then tears can't go out and tears will just come out onto the face. So this is the normal anatomical pathway. Right? Now, hold on. Point values. Point right. Draw spot. Right, okay, come on. So this is where the tears are produced in the lacrimal gland. Right? That is at the lateral edge of the upper eyelid. So then there are some small ducts which bring the tears into this space. What is this space called? Conjunctival sac. So tears come to the conjunctival sac, and normally they would drain via the drainage pathway. So you get the lacrimal puncta here, right? Two small openings at the lid margins. From there, tears drain via the lacrimal canaliculi. You can see about the first few millimeters are vertical, then it goes more or less horizontal. Then the two of them join together to form the common canaliculus. And that enters into the lacrimal sac, right? And then from the lacrimal sac, there is the nasolacrimal duct through which tears enter into the inferior meatus of the nose. And this area is called the valve of Hassner. And that is usually the commonest site where you will find an obstruction. Stuck without Oh. Right. Okay. So what happened to the child? A massage of the lacrimal sac was advised. Right? So by massaging, you try to force the tears down the drainage pathway and hope that it will overcome the obstruction and open up the lacrimal sac. So to do the massage, you have to know the relations of the lacrimal sac. So what are the relations? Yeah, so if you look at the orbital anatomy, you will find that the lacrimal fossa is here. Can everyone see the pointer?
Yes, sir.
Okay, so this is the place where you find the lacrimal sac. So the anterior, you will get the anterior lacrimal crest, which is formed by the maxilla. And posteriorly, get the posterior lacrimal crest formed by the lacrimal bone. So in between, you will get the lacrimal sac. So if you want to massage, you have to press at that point. Okay. I just go to video. Video start video. Okay. Right. So it's better. Right. Okay. So this is the place where you have to do the massage. Right here has to be posterior to the lacrimal crest. You can feel the anterior lacrimal crest here. You have to go posterior to that to do the massage. No point doing the massage here. Right? There is nothing but skin and bone here. Okay. Right. Okay. Screen share I can. Screen share. Okay. Let's share screen meeting. Yeah, come on. Okay, so that is the point. Yeah, nanny. Right. So between the anterior and posterior lacrimal crest. So feel it on yourself and see. Right. So there was no improvement in the symptoms at the age of 13 months, and a probing was recommended. So you pass a probe through the lacrimal punctum and keep going forwards through the lacrimal canaliculi, common canaliculi, lacrimal sac, and then the nasolacrimal duct. So you have to keep going until you overcome the obstruction at the valve of Hasner. Okay, so next problem. A 56-year-old female who had recently been diagnosed with diabetes was referred to exclude diabetic retinopathy. She had no complaints about her vision, and there was no diabetic retinopathy on examination. But the optic discs were a bit abnormal. Yes. Now, what can you say about the optic discs? Yeah, can someone tell me? What can you see? So this is the optic disc, and inside you see the optic cup. Okay. So you see the nice kind of orange color rim of the normal optic disc, and inside you get the yellowish area, which is the optic cup. Now, normally the optic cup is about less than half the width of the optic disc, but here it's almost 90%. So what is happening? The optic nerve is getting progressively damaged, right? So what do we call that condition? Progressive damage to the optic nerve. That is called glaucoma. Have you heard of the term glaucoma?
Yes.
Right. So in glaucoma, it's usually, but not always, due to an increase in the pressure inside the eye. So the pressure will compress the optic nerve, and gradually the optic nerve fibers will get lost. And this cup becomes bigger and bigger. Right? So once it's bigger, it almost completely obliterates the optic disc. By that time, there will be no nerve fibers left, and the patient will be totally blind. So our objective is, when you diagnose a case of glaucoma, you have to prevent it from getting to that state. Right? Treat them, reduce the eye pressure, and treat them so that they don't go into complete blindness. So the fundus examination shows cupping of the optic discs, and the intraocular pressures were 24 in the right and 26 in the left. So the normal pressure is 10 to 21. So that means the intraocular pressures are elevated. So why is the pressure elevated? Here, similar to the first problem, why do you think the pressure is elevated? What are the possibilities? Can someone answer? Now in problem 1, we had tearing. So we said increased production or reduced drainage. So it's the same thing with the eye, inside the eye. There is either too much aqueous production or inadequate aqueous drainage. So that is why you get an increase in the pressure. So usually, as with the tearing, usually it's not a problem with increased production, but it's a problem with reduced drainage. So we have to know how tears are getting drained. Right? Now, normally, tears are produced here. Right? This is a cross section of the iris and ciliary body. So you can see the iris here, right? And the ciliary body here, posterior to the iris. So in the ciliary body, there are ciliary processes. So these are the processes that secrete aqueous. So aqueous comes here into this space. What is this space called? That is the posterior chamber. And from the posterior chamber, it goes through the pupil. This is the pupil here, and goes into the anterior chamber. That is the space here. And from the anterior chamber, they are drained via the trabecular meshwork. Right? So we'll learn a little more about the trabecular meshwork and the drainage anatomy. Right. So this is the trabecular meshwork. Now you can see the iris here, right? And the ciliary body is a little more posterior here. Sorry, little more posterior here. This is the ciliary body here. So that is where aqueous is produced. Then it goes round the pupil into the anterior chamber. And from the anterior chamber, aqueous gets drained into through what's called the trabecular meshwork. This area is a series of trabeculae, right, which kind of forms a net, and it allows fluid to drain into this place here, these small venous channels, which are called the Schlemm's canal. From the Schlemm's canal, there is communication into the episcleral veins, and fluid drains into the venous system. So most of the time, the site of obstruction is at the trabecular meshwork. So if there is obstruction here, then fluid builds up, fluid can't drain properly, and the pressure goes up. So you can see these structures. There is a way of looking at it. So you can see the trabecular meshwork. Anterior to the trabecular meshwork, you get a bit of it joins the cornea, so you get the corneoscleral junction here, then the trabecular meshwork, then you get a bit of sclera coming posteriorly. You can't see it very well in this picture. That is called the scleral spur, and posterior to that you get the ciliary body. So gonioscopy was performed to assess the iridocorneal angle. A gonioscopy involves putting a lens onto the eye and taking a look at the angle or that space between the iris and the cornea. So that is called the iridocorneal angle, and there are several structures that you can identify. So this anteriormost one, brownish one, is called the Scholby's line. That is the corneoscleral junction. Then posterior to that, this white one and this brown one, those two are the trabecular meshwork. So the unpigmented and pigmented parts of the trabecular meshwork. Then you get the scleral spur, this white band here, and then you get the ciliary body. So this shows that all these trabecular meshwork structures are visible, right? So that means the angle is open. So we call this an open angle glaucoma. Whereas if the trabecular meshwork is not visible, that means iris is covering the trabecular meshwork, then we call it a closed angle glaucoma, angle closure glaucoma. So that is important. There is clinical importance because that has some significance. Right, so in this case, because all the structures were visible, a diagnosis of open angle glaucoma was made and medical therapy was started. Okay, problem 3. A 26-year-old male presented to the eye clinic with a history of double vision after trauma to the back of the head. So trauma was to the back of the head, but there was double vision. His head was tilted to the left, chin was turned up, and face was also turned to the left. Go again. Video right. So his head was tilted to the left, chin was up, and face was also turned to the left. So that was the posture that he was adopting. Okay. Right. So, when you examine the eye movements, it showed that there was a deficit in the down gaze on adduction. So, medial down gaze was affected of the right eye. So, what is the diagnosis? Yeah, can someone tell me something about the diagnosis? What kind of problem it is at least? Okay, so nobody is talking.
Sir, is it entrapment of the inferior rectus muscle?
Entrapment of the inferior rectus. Okay, that is possible. So it's some kind of problem with one of the eye muscles. Something has happened to one of the eye muscles, right? We will see why your muscle is wrong. But anyway, it's a good start. Okay. So we think that there is some problem with one of the eye muscles. So one eye muscle is not working. Therefore, one eye is pointing in one direction and the other eye is pointing in another direction. Okay? So that is why he is having a double vision. Right. So we will basically summarize the vertical muscle action. So it's obviously a vertical muscle, right? Now the horizontal muscles I won't go into because they are very easy. The medial rectus will adduct and the lateral rectus will abduct. So that is very easy. I won't go into that. But when it comes to the oblique muscles, it's a little more complicated and we will learn why that is. So the superior rectus, primary action is elevation, and inferior rectus, it is depression. Whereas the superior oblique is intorsion, inferior oblique is extorsion. Right? Now the secondary action of these muscles, superior rectus is an intortor, inferior rectus is an extortor. And superior oblique is depression, inferior oblique is elevation. Now this might sound confusing why the superior oblique is a depressor and inferior oblique is an elevator. That is why I am going to demonstrate these things and show you how it happens. Okay. And if you want to remember, there is a mnemonic, SINRAD, SINRAD, superiors intort. So both the superior muscles will intort, right? SINRAD. Recti adduct. Right? That's to do with the tertiary action, right? We'll come to that later. Right. So when you study the anatomy of the muscles, you will see superior rectus and inferior rectus. Then you have the oblique muscles. The inferior oblique originates from the flow of the orbit and gets attached posterior to in the globe. Superior oblique originates at the orbital apex, but it goes round a structure called the trochlear, which is located in superomedial in the orbit. So then it turns backwards and again is attached posteriorly in the globe. So although the anatomical origin of the superior oblique is in the orbital apex, the functional origin is at this point, the trochlear, which is on the superomedial wall of the orbit. Right. Now it all comes down to this. This is what is important. Now if you look at where these muscles attach, now the superior rectus and the inferior rectus also, they are not exactly in the sagittal plane. Right? So this is the globe. This is the sagittal plane. So in the primary gaze, eye is pointing forwards. Right? But the superior rectus is at an angle to the sagittal plane. So that is important. I will show you how that works. Right? And similarly, the superior oblique is also at an angle to the sagittal plane. It's about a 51-degree angle. And it inserts posterior to the globe, posteriorly in the globe, posterior to the equator. So I'll show you how these movements come about. Now, I'm sorry you didn't have enough warning, but if you had some warning, I think it would have been good if you were able to get hold of some a rubber ball and a ribbon. Yeah. Right, I think lighting is a problem. Right. So, right now this is the ball. I have marked the cornea here on the anterior surface so that you know what is happening, right? So the cornea is here and you can see the equator of the globe here. So now the eye is pointing forwards, right? Now, although the eye is pointing forwards, if you look at the superior rectus muscle, it is not exactly in the sagittal plane. It is at an angle. Right? Can you see? So the eye is pointing downwards, but this is at an angle. Okay. So because it's at an angle, when the eye is pointing forwards, it's a bit complicated, but now we learned that the superior rectus is an elevator. So, but thing is, the elevation mainly occurs, now imagine that this is the right eye. Okay? The elevation occurs when the eye is abducted. So when the eye is pointing this way, what will be the action? It will be elevation, right? Like that. But when the eye is abducted, when the eye is pointing medially, what will be the action? It will be a torsional movement, right? So it will be intorsion. Okay. So the superior rectus is an elevator, but the elevation mainly occurs when the eye is abducted. Okay? And it is also an intortor, but the intorsion will occur when the eye is adducted. Okay? Can you understand that?
Yes.
Right. So it's the same with the inferior rectus. I won't explain that again. Now we'll come to the superior oblique. Now, as I said, the superior oblique originates, or the functional origin is the anteromedial part of the orbit. So it comes from front and it forms a 51-degree angle and it is inserted posterior to the globe. So again, imagine that this is the right eye. So with the oblique, what happens? When the eye is abducted, what will be the action? Primarily, it will be a rotation, right? When the eye is adducted, it's a depressor. Okay. So that is how these muscles work. The same with the inferior oblique. Right? So did everyone understand this? Because I don't mind explaining this 2-3 times if someone didn't understand. Anybody who didn't understand? I don't mind even explaining it for one person. Okay, I'll explain it once more, right? So the oblique muscles, now this is the right eye. Oblique, the action will be when the eye is abducted or pointing outwards, it will be intorsion. But when the eye is pointing inwards or adducted, action will be depression. Then when it comes to the recti, superior rectus, when abducted, it's an elevator. When adducted, it's an intortor. Okay? Right. So we get right. So we get back to the presentation. Cool. Right. So those are the actions of the muscles. Right. So now can everyone understand why the superior rectus is an elevator and an intorsion, inferior rectus, now particularly you have to understand why the superior oblique is a depressor and inferior oblique is an elevator. Because that is where things can get confused. Then coming to the tertiary action, that is of course not difficult to understand. Superior recti and the inferior recti are adductors. I show you that again. And the obliques are abductors. Right. So if you're coming back to this globe, so it has now because this rectus is slightly oblique, 23 degrees. When the rectus muscle works, it also causes a bit of adduction, right? But it's a very minor action, right? Along with the elevation, causes a bit of adduction. Whereas the oblique muscle, because it originates from the medial side and goes to the posterior aspect of the globe, it's a slight abduction can be there. But don't bother too much about the tertiary actions. Right. Right. So we get back to the problem of our patient. So he has double vision. We'll get back to the problem. Yeah. Examination showed that there was a deficit in the medial down gaze of the right eye. So when the right eye was trying to look medially and down, there was a problem. Right? So what is the muscle that moves the eye downwards in adduction. When the eye is medial and when the eye is turned medially, what is the muscle that pulls the eye downwards? Anybody? I explained that earlier. I'll try to show you again. Yeah, so when the eye is pointing medially, so what are the depressors? The inferior rectus and the superior oblique. So, like with the superior oblique, with the superior rectus, inferior rectus will move the eye downwards, mainly abduction. Right? When it's like this, it goes down. Right? When it's medially, it's a torsion. Right? So, it's an extorsion movement that you will see when the eye is like that. When the eye is adducted, what you will see is a extorsion movement. Right? So it's not the inferior rectus. So what about the other depressor? The superior oblique. So superior oblique, I told you, the depression is primarily when it is adducted. Whereas when it's abducted, it's a intorsion. So what is the muscle we are talking about? Yeah. So we are talking about the superior oblique. So he has a problem with the right superior oblique. So to correct that, what does he do? He will try to move the eye in that direction to try to compensate. Right? So problem with the superior oblique, so he can't look down. So he'll move both the eyes up to try to compensate. So chin up and the face turn, right? Because the restriction is on medial gaze, right? He will try to move the head that way to minimize that. And the torsion, the head tilt, will be to try to correct the torsional disparity. Okay. So did everyone understand the eye movements? Because that is a difficult part, right? Did everyone understand the eye movements? Okay, we get on to the next problem. A 23-year-old male had a history of trauma to the right eye and complains that he can't see out of that eye. On examination, he was found to have no light perception in that eye. So even if you shine a torch, he will not be able to say that there is light. A light was shone onto the left eye, which resulted in constriction of both pupils equally. So pupils are equal and reacting to light. Right? But, so why did this happen? So he has a problem with the right eye. Right? So when you shine the torch to the right eye, there isn't much of a reaction. Right? So we have to see what's happening. So when the light was shone onto the left eye, what happens? You can see that the retina of the left eye gets stimulated and light travels right? So this is the normal pathway. Actually, this diagram is slightly wrong, right? I'll tell you why. Right? So the light goes from here. The half of it goes to the other side from the optic chiasma, half goes this way. And then from the optic tract, actually it's not from here, it's from here. Some fibers leave the optic tract and they go this way and they go to a place called the pretector nucleus. Sorry, right, diagram is correct. I'm sorry, I'm wrong. Okay? So light is shone onto the retina and half of it goes to the other side, decussates at the optic chiasma. Half the nasal fibers go on the same side, and then they go to the pretector nuclei in the midbrain. From there, again, there are connections to the Edinger-Westerfeld nuclei of both eyes. From there, you get fibers coming to the parasympathetic fibers from the third nerve. They will go and constrict both the pupils. So that is what happens in a normal light reaction. Right. So this is what happens. Yeah, so actually here you shine the torch in one eye, there is no reaction. Sorry, there is a reaction and both pupils are constricting. Then you quickly move the torch to the other eye. Both pupils are dilating. That means there is a problem with the optic nerve of this side. Right? The optic nerve is not conducting anything beyond that. That is why there is no way that either of the pupils can dilate. Whereas when you shine it onto this side, that optic nerve is working, so both pupils will constrict. So this is how you get the pupillary light reflex, and this is a very important sign to look for. Because you can see medical students, what they normally do is they check whether the pupils are equal and reacting to light. That is all they do. So these pupils are equal and they are reacting to light. So you will miss this sign if you don't look properly, if you don't move the torch from one eye to the other and see what happens. So this sign is called a relative afferent pupillary defect. And it is an essential part of your neurological examination. Right. Okay, so next problem. A 76-year-old male suffered a stroke involving the vertebrobasilar territory of his left side. He complained of being unable to see on the right side. So he had a problem with the left side of the brain and he can't see the right side, not the right eye. He had 6/6 vision in both eyes. So both eyes have normal vision, but he has a problem with the field. Visual field of the right side is gone. His perimetry was like this. So imagine that you are him, right? You can see well from both eyes, you can see the left side well. But from both eyes, you can't see the right side. Right? So what kind of field defect is this? This is called homonymous hemianopia. Right? So it's a right homonymous hemianopia, but there is something else. Here, what is this? This part, you can see the center. So that is the macular vision, where the macular part of the visual field, that is intact. So that is called macular sparing. So sometimes you can get a homonymous hemianopia without macular sparing, or you can get it with macular sparing. So we will learn the significance of this later. So what type of field loss? It's a right homonymous hemianopia with macular sparing. So what area is the lesion? Yes, what is the area that is involved in the entire right side? What are the possibilities? We will look at the visual pathway. So as I said, at the optic chiasma, the two halves of the two retinae go to the two sides. So in both eyes, if you can't see out of the right eye, sorry, of the right half of the field, that means the lesion is on the left side and it is somewhere after the optic chiasma. So it's either in the optic tract, the atrogenicated body, optic radiation, or the occipital cortex of the left side. So, and why does he have normal vision? We will come to that, right? That is because there is a thing called macular sparing. We will come to that, right? So, these are the visual field effects that you normally get. So, you can see the right, this side, that is the right visual field is represented in black. So the right half is seen by the left half of the retina in both eyes. So that is represented in black. And the other half of the visual field is represented in gray. So obviously, if you get a lesion affecting the optic nerve, then you won't have any vision out of that eye, and you have completely normal vision in the other eye. Then if the lesion is in the optic chiasma, you get a cut like this in the optic chiasma. Then both the crossing fibers on both eyes will be lost. But the normal non-cross fibers of both sides will be intact. Okay. So then both sides you will lose the temporal or lateral vision of both, lateral visual fields of both eyes, but the medial visual fields will remain intact. Then this is of course highly hypothetical, I won't go into that. Then anything after that in the optic tract or optic radiation, you get a homonymous hemianopia, right? So problem here means you won't see anything on the opposite side with both eyes. Then optic radiation also takes two different parts. Right? The inferior fibers go separately and the superior fibers go separately. So if you have a lesion which affects only the inferior fibers, you get a superior field loss. If you get a problem with the superior fibers, you get an inferior field loss. So we call those contralateral lower quadrantic hemianopia or upper quadrantic hemianopia. Then in the occipital cortex, now usually if you get a problem with the optical visual cortex, again, you will expect something like this, a homonymous hemianopia. But the problem is the occipital cortex. Now, this is the occipital cortex. So the blood supply is mainly from the middle cerebral artery, like this. So all this area is supplied by the middle cerebral. But the very posterior part of the visual cortex, this is supplied by the posterior cerebral, right? So all this is supplied by the posterior cerebral. The very posterior part gets an additional supply from the middle cerebral. So in certain situations, even if you get a blockage in this posterior cerebral artery and you get a homonymous hemianopia on the opposite side, the macula might still have some oxygenation taking place. So because of that, you can get what's called macular sparing. Okay. Right, next problem. A 76-year-old lady was found to have reduced vision in both eyes. Visual acuity was 660 and 460. This was the appearance of her eyes. So what does she have? Yeah, cataracts. So she was booked for a left phacoemulsification with an intraocular lens implantation. Pupils were dilated using tropicamide and phenylephrine. So tropicamide is an antimuscarinic drug and phenylephrine is a proadrenergic drug. So both of these will dilate her pupils. So this is not really anatomy, but for physiology, you can work that out. So a local anesthetic was injected into the retrobulbar space. So she was found to be anesthetized. She did not have any movements except for a side rotary movement of the eye. Okay. Why did the rotary movement persist? So we will see. Now, if you look at this is the diagram of the superior orbital fissure and the optic foramen. And around this, you get the rectus muscles. And they form a kind of a tendinous ring enclosing part of the superior orbital fissure and the optic foramen. So when you give an anesthetic into this space, what will happen? All the nerves in this space will get anesthetized. So oculomotor nerve, right? Nasociliary, that is a sensory nerve, abducens nerve, all those will get knocked out. But the trochlear nerve is outside. So trochlear nerve is here and the trochlear nerve will escape. So the trochlear nerve supplies the superior oblique. And as I said, superior oblique is a muscle. Primary action is intorsion. So the intorsion movement can sometimes remain after giving a local anesthetic into the retrobulbar space. So incision was made at the corneoscleral junction. Circular opening was made by tearing the anterior capsule of the lens. A phacoprobe, that is an ultrasonic probe, was inserted to sculpt and extract the lens material. So this is what it does. It breaks the lens into pieces and sucks them out little by little. And during the procedure, there was some damage to the posterior capsule. So you get the anterior capsule, then you get the lens matter, and posterior to that you get the posterior capsule. And a fragment of the lens fell into the vitreous. Now that is a major complication, right? Because the lens, normally the vitreous is a very inert structure and the lens matter is a very antigenic substance. So it goes into the vitreous, that means it will elicit a major inflammatory reaction. So to avoid that, you have to remove that lens fragment. So you make 3 openings in the sclera, 3.5 millimeters behind the corneoscleral junction. Now, why was this site selected to make the incisions? I will tell you. So here we have the cornea. This is the lens, the anterior capsule and the posterior capsule. And behind that, here you get the iris and then the ciliary body and then the retina. So if you try to make an incision here, it will damage the retina. If you try to make the incision somewhere here, it can damage the lens. So because of that, there is a safe zone where you can enter the eye, that is called the pars plana, that is part of the ciliary body. So through the ciliary body, you can enter the eye safely. So if you want to give an injection into the eye, that is the site we choose, and through the ciliary body. And ciliary body, there is an anterior pars plicata, where you get a lot of ciliary processes, and that is very vascular. You avoid that. posteriorly you get the pars plana, which is a very bare area. So that is how you enter through that. Okay. Right. So that is the point where you enter. So then you introduce instruments through that and remove the lens fragment and the vitreous. Right? And the intraocular lens was placed between the anterior capsule and the iris, because normally we place the lens between the anterior and posterior capsules. But because the posterior capsule was damaged, if you put it there, the lens also will fall into the vitreous. Therefore, it was placed anterior to the anterior capsule, that is between the iris and the lens. Okay, next problem. A newborn baby was referred by his pediatrician because the baby had an abnormal shaped pupil. That was the pupil. Now, what is this called? Can you see the iris is deficient here and the pupil is kind of a keyhole shaped pupil. So that is called iris coloboma. When you look at the fundus, you have seen what a normal fundus looks like, but this fundus, you can see a big area where the retina is absent. This whole area is white. So that is also called coloboma. So that earlier we saw an iris coloboma. Now this is a retinal coloboma. So that means that in one area, development of all the structures, the iris, the retina, the choroid, everything is deficient. So there is some problem in the way that the eye has developed. So if you, how did these changes come about? So if you remember, the eye is formed by the extension of the forebrain, which is called the optic vesicle. So it starts as optic vesicle, and then the optic vesicle invaginates like this to form the optic cup, right? And when it invaginates, a bit of the skin or surface ectodermis also gets pinched off, and that forms a future lens. And the lens gets its blood supply by a vessel that comes in the just under the optic cup. So now the optic vesicle is forming into an optic cup, right? But the process is such that it doesn't happen centrally. The invagination occurs on one side. So invagination is from a side like that. So the retina, iris, everything forms like that. And later, this gap is bridged and you form a complete globe. But if this gap fails to bridge, then what happens? You get a deficiency in the structures in that gap. So that is the coloboma. So you can get iris coloboma, retinal coloboma, choroidal coloboma. So all those structures can be deficient, right? And you get this vessel called the hyaloid artery coming from the optic nerve to supply the lens vesicle. So in the fetus, the lens has a blood supply. But this hyaloid artery has to regress later, because otherwise you will see some structure floating in the vitreous. So to avoid that, normally it regresses, but sometimes it may not. So that is how you get a coloboma. And then, so you can get various other abnormalities in the eye due to failure of the lens and other things to regress. So this is called a persistent tunica vasculosa lentis. Now you can see this is the eye, this is the lens. Lens is still having blood vessels coming. So these will interfere with the clarity of the lens and the vitreous, right? So there will be a deficient vision. So that is how it, because these In development, the lens gets a blood supply and some of these vessels fail to regress. This again is a remnant of that vessel. You can see the optic disc here, and you can see a kind of a stalk coming like that. Right? So that part of that thyroid artery has remained as a fibrous band. So that will again interfere with vision. Here, again, the lens also gets a blood supply from the iris. So these connections have remained. So this is called a persistent prepupillary membrane. So you can get various anomalies due to that. Right, so that concludes our talk. Do you have any questions? Anybody got any questions? No. Okay, then we'll call it a day. Okay. Thank you very much.
Thank you very much, sir.